We can do it, yes we can. Become the leading star. Putting our patients first will make me lead by far.
We work as one family. We work hand in hand. We work to make our nation proud. We'll be the best in the land.
Putting our patients first will make me the leading star. Putting our patients first will make me the best by far. Putting our patients first will make me the leading star. Putting our patients first will make me the best by far. We heal with pride and passion. We heal with faith and love. We heal with truth and harmony. As sure as God's above, with God sent to guide us, our skills grow day by day. Putting smiles on people's faces, that's the Miyot way. Putting our patients first will make Miyot the leading star. Putting our patients first will make Miyot the best by far. Putting our patients first will make Miyot the leading star. Putting our patients first will make Miyot the best by far. We can do it, yes we can. The best by far. We can do it, yes we can.
We can do it.
The leading star. We can do it, yes we can.
Yes, we can.
The best by far. We can do it, yes we can. The leading star.
Welcome everyone to this series of Hindu Wellness webinar. This edition will be on the impact of epilepsy in children and its management. Road towards epilepsy cure. We have with us two eminent panelists who between them have treated thousands of patients in Miyot International. Dr. Hrishikesh Sarkar, Director, Department of Neurosurgery, will be speaking on surgical options in epilepsy. He has around 20 years of experience and has performed over 3,000 brain and spinal surgeries with results on a par with the leading international centers. He has special proficiency in keyhole endoscopic and minimally invasive surgeries for brain tumors in both adults and children. He has a rich experience in epileptic surgeries across all age groups. He's introduced combinatorial neuro-restorative strategies such as nerve transfers and epidural cord stimulation in paraplegia, hemiplegia due to stroke, traumatic brain injury, and spinal cord injury. His innovations include Bellow Localizer, a tool to improve accuracy of shunt placement, novel minimally invasive surgical approach, shunt protection device, and animal model to study stroke. Welcome, Dr. Rishikesh Sarkar. We have with us Dr. Bindu Tankapan. She's a senior neurologist at the hospital, and she'll be speaking on impact of epilepsy. She has over 17 years of experience in the field of neurology, and she has treated more than 1,000 stroke patients. Her expertise is on stroke management, aided, and it aided her to start the first thrombolysis unit in Alappuzha district in Kerala. Her special interests are in management of stroke, epilepsy, and teaching. Welcome, Doctor. I request Dr. Bindu Tankapan to start her presentation.
Thank you very much, Sujata ma'am, for that kind introduction. And without much delay, I would like to go into for the presentation. Are my slides visible?
Yeah.
A very good morning to one and all. Today we are gathered here to have some awareness about the impact of epilepsy. Though at this moment, I cannot talk about the impact of epilepsy, about the whole spectrum of population, but about children. And why children, you might ask? Because as you all know, it's a developing brain, and therefore any insult on that will produce long-standing, devastating consequences in the form of developmental delay and cognitive impairment. Now, when I talk about epilepsy, you might ask, what is this? Just a simple terms, brain is full of small balls like neurons and wires from it called nerve fibers or axons. And these axons are the ones which carry electrical impulses, just like our electrical wires. Now, just remember, if there any electrical system, if there is a short circuit, what will happen? Flame, isn't it? So just like that, if it's in the brain, a short circuit occurs. That means it's an abnormal electrical discharges. So that will amount to the dysfunction of that part of the brain, which is supposed to function. Suppose it affects, that from that part spreads to the other part, other side of the brain. So that means it can also lead on to the loss of consciousness. So it can be, with the awareness or without awareness. Most of the time, we just don't know the term meaning. Seizures, epilepsy. Sometimes we, hand in hand, we use the same terms, but it's not one and the same. When you say it's an epilepsy, it is a disease condition which is characterized by more than 2 unprovoked seizures. That means after the blue, it comes with about 24 hours apart. Now, when you call seizure, that means that it's a sudden, uncontrolled electrical activity producing, could be resulting in some change of the behavior or sensation or abnormal movements, which is more common. So seizure is just an event. About 10% of the population normally can have one episode of seizure in their lifetime, but not epilepsy. Epilepsy means you need to have the above defined condition, and it is a disease entity, and that is what we are talking today. Now, it can start from any age, either from the childhood, or it can also occur de novo in people over 60 years of age. And the causes can be very many, can be from congenital malformations, the birth, or genetic problems, or infections of the brain, stroke, trauma to the head, tumor of the head, and metabolic conditions. But most of the time, after extensive investigations, 70% of the population will have will not have a known cause. So we call idiopathic. Now, this is coming to about second largest chronic neurological disorders all over the world. Now, what is the good part of this is that the good news is that it is 70% is fully treatable. And what is the bad news about it? 7 out of the 10 people with epilepsy did not get treatment. And this is more so in a developing country like India, where people are not aware of whether that is a seizure or not. And if at all, there is no trained personnel, especially in the remote areas of India. All the more, there is something like a social stigma. That means people think that those who are having a seizures are having some ghosts inside their body, or they're mad and that's why they do like this. And therefore, the parents of the children think that if I take the child to the doctor, everybody will come to know, my neighbors will come to know, my relatives come to know, school will come to know, and that will make the child isolated. Not only that, that will further impair them a good future. Like if it is a girl child, they'll think that, okay, this child will not get married when she grows up, and she might be having a doomed future. So that is a social stigma still prevalent even after so many decades of awareness about the epilepsy. Very pathetic situation. And that's the same reason why we want to do some awareness programs about epilepsy like this. And last but not the least, in the developing country like India, we have a small group of population who are not affordable to buy the medications. Now, the impact depends on various factors. The first and foremost is the frequency and the severity of the seizures. Like if it is occurring daily or monthly or weekly, it becomes a cumbersome affair for the child. And associated depression. Sometimes they'll have a worry that what if I get seizures when I'm going around and playing around? What if I get seizures in the school? So a lot of anxiety about the seizures, especially in the parents more than in the child. Child may not be aware of all these things, but the parents become more anxious. Plus, there is a side effects from the anti-seizure medications. It could be dizziness and nausea and feeling very tired and sleepy all the time. And last, the stigma. So you have the patient with so many structural lesions or sometimes functional lesions, and you have the epileptic medications, psychiatric comorbidities like depression, anxiety. Plus, there might be some developmental delay if in the case of child, in rare cases. Now, how that will impact the life of the child is because when the child interact with the family members and with the friends and the cultural environment as a whole, society as a whole, there is an influence from them towards the child. Some still treat child to have that, ghost sitting inside and get isolated from the whole general population. So that is being reflected in the education while they grow up and go to job, or in the case of healthcare also that still prevails. Now the medication is to decrease the seizures. The goal of any treatment whatsoever is to free from what the patient is having. So much so with seizure. So the seizure freedom is actually very, very, you cannot tell that you are free from seizures, especially when you are giving medication. It is just preventing the further recurrence. In a group of individuals, that increase in frequency will be coming down and the seizures can be totally freed. That is a very small amount of population. In 70%, it will decrease the recurrence. Now, what about the 30%? You add new drugs, then again more and more drugs. So when it becomes more than 2 drugs, the maximum tolerable dose and the patient is not responding to your drugs, there is no point in adding 3rd, 4th, 5th drug because that is less likely to respond. There comes a role of surgery and neuromodulation procedures like vagal nerve stimulation, as well as diet. So the surgical aspect, my colleague, Dr. Rishikesh Sarkar, will be elaborating more upon it, as well as about the vagal nerve stimulation. There is a special diet called ketogenic diet, which can improve the seizures. Now, this is a story of a 2-year-old boy. At the age of 4 months, the mother noticed seizures, and the baby, whenever the baby used to get seizures, the mother used to take snaps, and that is one of the important tool to diagnose epilepsy nowadays. So parents, all of those watching who have the child who have epilepsy, have, there is a chance that these seizures can be brought to doctors' notice by taking a video clipping rather than observing it and telling out. A picture represents 1,000 words. So now you are able to find out that the child is having tonic posturing and clonic movements of the limbs. This has occurred in the baby's home. So this child had, when they came, had 3 drugs, and that was optimized to 2 drugs and was put on ketogenic diet. You just don't believe it. The baby could decrease the number of seizures, plus the baby was sitting quiet, and there is a lot of change in the behavior. The baby was hyper alert and hyperactive and all sort of, tantrums he used to do it. The mother is so happy that the baby not only had control of seizures, but decrease in the behavioral modification also could occur. So the new definition is that the disorder of the brain with an enduring predisposition to generate the epileptic seizures, plus its neurobiologic, psychological, cognitive, and social consequence of this condition. So that means we need to take care of the whole aspect. So as an individual, we need to take self-care, and then we need to know about what all things, especially the treatment is an interdisciplinary treatment plan, which has got its own importance, and we have to include the psychosocial worker, the psychologist, the dietitian, physician, etc., who will tackle the psychosocial aspects also. So living with epilepsy means we need to be aware of what is that and how can we prevent and how can you reckon and when to meet the doctor and how to improve the quality of life of that individual. These are the websites that is all over the world people search for to find out the new and new modalities of treatment and what to do when an epilepsy occurs. And you can know a lot about your own type of epilepsy from these, websites. These are all WHO websites and Epilepsy International League Against Epilepsy. So these are international websites where you get a lot of educational resources for combating epilepsy. So we think that we have the expertise as well as the infrastructure to treat epilepsy and towards epilepsy cure. Thank you very much for the patient listening.
Thank you, ma'am. That was extremely interesting. And I did not know that such young children also suffered from epileptic seizures. Your presentation was awesome. Thank you very much. I request Dr. Rishikesh to please start his presentation. It was a learning experience. Thank you very much.
Good morning, everyone, and thank you to the Hindu group. Thank you to the management committee of MIOT International for giving us the opportunity to come and give the talk on epilepsy and its management. Being a neurosurgeon, I would be focused on what are the surgical options available to manage and cure epilepsy. This slide shows a very interesting number, 4994. It's a palindrome number. If you can read from both backwards and forwards, is going to be same sequence. The importance of this number is that a person who started on one medicine has about 50% of chance of being free from epilepsy. However, when two medicines are required, that number drops down to just 9%. That means only 9 out of 100 will have some control over epilepsy. What if we add 3 medicines? Hardly anything, 4%. That means 96% of patients will continue to have epilepsy despite being on 3 medications. What if the surgery is offered as an option? It has a potential to treat about 50 to 95% of patients depending on the type of epilepsy, depending upon the networks associated and various other factors. And this clearly shows that any patient who is on 2 medications and more has a significant chance of being able to cure of his illness, cure of his epilepsy because of a surgical option. And this is what is known as medically refractory epilepsy. To sum it all, surgical options are nothing but 3. Basically, finding where the problem is in the brain. Once the problem is found, to burn it. Literally doesn't mean by burn we put in some fire and burn it. We use surgical tools to have a precise destruction of the tissue, or stun the tissue, stun the abnormal tissue. It's just like defibrillating the heart, it's quick starting the heart, jump starting the car. It's similarly, this is called as neuromodulation. And neuromodulation, like vagal nerve stimulator, can be used to jump start the brain. Things like deep brain stimulation can be used to jump start the brain and correct the cause. Now, to give the enormity of the problem, it's very simple to say find it, burn it, and buzz it. But however, just to give a brief idea about the complexity of the issue, this is a photograph and you can see a lot of parakeets over there. And for a moment, please look very closely in this photograph and try to identify a butterfly. There's a butterfly hidden somewhere, and name the color of the butterfly. You got 10 seconds. I'm going to wait over here. In Q&A box, you can say, or you can write the color. Sorry, I think I've already given you that. Sorry, color of the butterfly. And imagine these parakeets to be normal neuronal cells, normal brain cells, and they should not be disturbed at all. And our role as a surgeon is to pick up the butterfly and then remove it from the cluster of the birds which you can see. So the time starts now. For next 7 seconds, if you're able to identify that butterfly and the color of the butterfly. 1. Please put your responses in the Q&A box, those who are listening. 1, 2, 3, 4, 5, 6. Right. Let me give you the answer. So there it is in the yellow circle, small butterfly with the color, it's pink. I'm sure that people are it's very easy to now recognize that. So just this complexity magnified into 1 billion or 100 million. And this is how we go about finding that abnormal focus, which is really responsible for abnormal activity arising out of the brain. And this figure also shows that the area which is enveloped in orange, that orange area which encompasses a problematic zone from where the abnormal electrical activity is starting, the symptoms where they're arising from, and any lesion or any tumor or anything associated with that. That entire orange zone is our target, and this is what we go about finding. And that orange zone is known as epileptogenic zone. And there are various strategies and various multidisciplinary things which are required to identify the correct candidate with an epileptogenic zone, which can be addressed surgically. So a participation, a multidisciplinary team is required to find out that epileptic zone and associated networks. So you need a participation of specialists like Dr. Bindu, who's a specialist in epilepsy, neuropsychologist, the neurophysiologist, our nuclear medicine specialist, and various other interdisciplinary people to identify and get across and find out the right candidate who would benefit with surgery. If you classify the surgical procedure, what is done for the epilepsy, the few procedures are for the diagnosis. That means to finding out the abnormal area in the brain. And there is something called a therapeutic. Once the area is found out, either, as I said, you burn it or resect it or you remove it or you stun it or you do neuromodulation. That's what it essentially means. And resective surgery essentially involves removal of a lesion or an abnormal area which is seen on the MRI scan. Sometimes it is seen on the MRI, sometimes it is not seen on the MRI scan. Or disconnect an abnormal area from the normal structure so that the electrical activity, the abnormal electrical activity, does not spread in the surrounding normal brain. Zapping the brain or stunning the brain involves either something called as vagal nerve stimulation, where one does not even need to open a brain. The vagal nerve is situated in the neck, and a pacemaker device can be placed within the vicinity of the nerve, and that can create electrical impulses which can normalize the electrical activity of the brain. Another form is deep brain stimulation, which also can be utilized in some form of epilepsy. So one would ask, how do you decide about resective or removal or neuromodulation or vagal nerve? It all depends on the age of the patient, the type of epilepsy, the localization of the network, and the characterization of something called as epileptogenic zone. We'll just try to understand by taking few cases. This is a 15-year-old child, female, presents with multiple episodes of seizures, about 3 to 5 episodes per day, leading to fall and frequent hospitalization. She's on multiple medications, huge dose, and medications per se, they're causing drowsiness, sleepiness, lack of memory, concentration, and other things. So this patient is being evaluated, and the MRI scan and a PET scan is being shown. The PET scan is colorful structure, which you can see in green, blue, and red and orange. MRI scan is black and white, and the arrow points towards an anomaly which is seen in something called as temporal lobe, which is located in the area above the ear, the right ear. And we also do something called as prolonged EEG monitoring. EEG is nothing but measuring electrical activity of the brain, and the EEG activity of this child corresponded or pointed to the problem located in the temporal lobe, as you can see in the diagram alongside. So this child, once we have localized that the problem is in the temporal lobe, and once we have ascertained that the memory is not going to be impaired after removal of this focus, then we embark on a procedure which is a resective procedure to remove this abnormal area. And that's what you are able to see on the right side panel. You can see the abnormal area documented in the white, and this area is removed on the adjacent panel. And this surgery is called as right anterior temporal lobectomy, and this is done under microsurgical guidance. A high-end microscope is used, and this is the human brain, and these numbers are actually the various areas which are being monitored for abnormal electrical activities, and that area is being identified, and slowly and gradually under microsurgical computer navigation guidance, this area is removed. You can see that abnormal area being removed, and the adjacent area, which is also looking abnormal, that is also being removed gradually, slowly, and steadily. There's another area which is close and deeper, which is responsible for the memory and making sure that memory area is not impaired. Various neurosurgical tools like robot, like neuronavigation, intraoperative continuous monitoring of the brain data, all this thing is being done very gradually and carefully, making sure that we are not giving any complications to the patient in terms of memory loss, paralysis, coma, or any other thing. So this child has had this surgery done and had an excellent outcome with seizure freedom being achieved. Second case, just a 6-month-old infant with some history of oxygenation issue during the birth, and the child has been having severe seizures since the second day of birth, 5 to 6 times per day, multiple episodes, and child's growth in terms of brain development, movement development, language development is not improving. It's something called as neurodevelopmental decline. Child also has a weakness, the right side, there is a weakness involved. And every possible drug combination in the world appropriate for this kind of epilepsy has been tried. And I'm not going to the elaborate list. Even the ketogenic diet, which Dr. Bindu just mentioned and emphasized on, that's been tried. Despite that, 5 to 6 times severe seizure, leading to something called as catastrophic epilepsy. Again, EEG shows catastrophic epilepsy. MRI shows, if you see, this is the right side of the brain, this is the left side of the brain. The entire left half of the brain is malformed, it is ill-formed, and it is discharging abnormally. So this patient underwent something called as functional hemispherectomy, where this abnormal tissue, which is not doing anything productive, but just discharging abnormally, is taken off, and very good result following the surgery. The 2 years from the surgery, child remains seizure-free. And not only that, at the end of 3 years, the child gained all the language, motor, and other cognitive milestones, which patient was not able to do that before. Case number 3, which does not require any cranial opening, head opening, 18-year-old male with staring spells. So continuous staring spells, brief, lasting for about 2 to 3 minutes, followed by severe seizures involving jerky movement of both hands and leg every month, with severe disability, not being able to go to the school, not able to write, not able to learn new things. And again, the same story, 1 medicine, 2 medicines, 3 medicines, 4. See, the 5 medicines have been tried and nothing is being controlled. And here he undergoes a very elaborative evaluation in our epilepsy board. EEG, video EEG, PET scan, MRI scan, everything is normal. However, the EEG scan shows that there is an abnormal activity which is coming up from both the hemisphere, and there's no one particular area which is responsible or identifiable for production of these kind of seizures. So these kind of a difficult epilepsy cases are generalized epilepsy. And in children, there's something called as Lennox-Gastaut syndrome or genetic generalized epilepsy. Vagal nerve therapy is very, very useful. And during vagal nerve therapy, as this cartoon demonstrates, there's a pacemaker device which is placed on the chest wall, and there's a wire coming out through that. And the tip of the wire has got a small micro electrode that is placed on the vagal nerve, which nerve is directly connected to the brain. And this device is so fantastic that it senses the oncoming seizure. And before it can convert into a major seizure, it will start discharging. And once it starts discharging, the electrical activity, specifically the abnormal electrical activity of the brain, that becomes controlled and the patient no longer has seizure. So in this case, as I described, with various current settings, patients became seizure-free after 3 months after the implantation, and he was gradually weaned off of 5 medications. And after 3 years, with a single medicine, he finished his schooling. And I'm very happy and proud to say, and this is what he gifted us. You know, he was not able to read and he wanted to learn new things. This is how he came up with a brilliant and beautiful drawing after VNS, maybe after 2 years after implantation. And we were so happy to see this outcome, which was not possible without having a collaborative teamwork and a very proper evaluation process. So I will stop over here and sum that surgery is definitely an effective treatment, not only to control, but also to cure epilepsy, especially in medically refractory epilepsy cases. However, we need to have a teamwork, and this kind of a teamwork is not there in most of the centers in India, and there exists a huge gap between the demand and supply. And here in MEOT International, as a team, we are here, and we are here to pave the road to cure in epilepsy. This is our epilepsy team. You see, there is no one particular person who is responsible for the epilepsy. It's a team. There are so many people who have been illustrated in this team. And I'm very proud to have each one of them with a unique ability and a passion to treat the epilepsy. It's not control. We are talking about curing the epilepsy, and we strongly believe that as a joint effort, we can indeed achieve that. With that background, I'm very happy to announce that we are soon going to have a specialized epilepsy clinic focused towards children, and that's going to start from the 2nd of May and it's going to last until 7th of May. The unique thing about this camp is the patient with epilepsy, particularly those with 2 or 3 medications, seizures are still continuing. They will be evaluated by our entire team under one roof with concessional rate as far as investigations are concerned, and they will get a fairly comprehensive idea about appropriate treatment and management which every single child deserves. Therefore, give your child a childhood. This is what the thing which are coming up with MEOT. Thank you very much again to the MEOT, to the Hindu group, and to our MD sir for this opportunity to present. I'll stop my presentation over here, and I would again thanks also Dr. Sujata Madam for introduction and for giving this opportunity. We'll leave the house open for discussion. Thank you very much.
Thank you, Dr. Sattar. Again, this was a very interesting presentation. Some of it we have not heard of earlier. And it's nice that you're starting a clinic for children. There is one question from somebody called Kavi Nandini Anandan. So she says her friend is 28 years old and he now has epileptic seizures. But the case is not serious, she says. Her friend is undergoing medication currently and he was identified at the age of 25. So she says she wants to know if it is permanent and whether he should take medications permanently. Would it be a lifelong thing for him? Can you please explain to her what it could mean to the patient? The very little data that she's given, so I think based on that we'll have to
Yes, most of the case usually it all depends whether it's permanent requirement of anti-epileptic drugs is to be taken or not depends upon the cost. Suppose after extensive investigations, we are not by EEG, by video EEG and 3 Tesla MRI with epilepsy protocol, if we are not able to find out the exact cause, the usual duration of treatment is about 3 years, because the rate of recurrence is maximum in the first 3 years of the onset, the first onset of the episode. So if so we call it as idiopathic. So in that case, in the first 3 years, if we'll putting the patient on anti-epileptic, so like this, if he responds, like if he has no further seizures and his EEG is normal, his MRI is normal, his neurological examination is absolutely normal, so we will taper at the end of 3 years and stop. That is the usual duration of treatment. But if we could find out any cause for that seizures with MRI showing structural changes, then if it is a resectable case, we have to subject for resection, and if it is at a in this resectable area, and if you have to prove that from that area the seizures occurs. That is the role of video EEG, FTG PET, and 3 Tesla MRI. Now, if we could find out there is a lesion, yes, that requires surgical resection. Now, suppose you have something like a stroke, or you have something like, another lesion which is not resectable but has to be treated with medication, then both needs pari-passu treatment. In this patient, I think with this limited amount, whether his MRI is normal, whether his EEG is normal. So without knowing that, we may not be able to tell up to what time period that he has to take the seizures. And lifelong or not, that depends upon the causative symptom. Like for example, when you have a head trauma and you have a major gliosis inside it. Gliosis means in ordinary terms a scar. Like when you have a small cut in your skin, it doesn't produce a scar throughout your life. You will never know that whether there was a cut or not. But suppose it's deep, very much deep, that will be seeing till your end of your life, right? That will be leaving a scar in your skin. Similarly, in brain also, if there's a serious insult in the form of brain hemorrhage and further trauma to the brain, so obviously it will leave a scar, and that needs lifelong treatment because that cannot be resectable out. It's a gliosis, it's a scar of the insult. Dr. Rishikesh, do you want to add anything onto this, to what I have said?
No, I think what you said is absolutely true, and I concur with what you are saying. The thing with epilepsy is the most of the problem I have seen with the control is most of the patients do not comply. What happens is once the seizures are under control, they either tend to forget this thing, and maybe under peer pressure or by circumstantial thing. So the problem is most of the seizure recurrence is due to compliance issue. And I think this also one strong message we need to pass to the public, that to be compliant with medications, not only the number of medication, the correct dosage, because as the age advances, the weight also increases, the body's metabolism also changes. So the dosage also needs to be optimized, and it's important to be in touch with the neurologist who can really keep a monitor and keep a check over the correct dosage, correct pattern of medication, and also keep a watch on the adverse effects associated with medication. Sometimes the adverse effect were very subtle, loss, a little memory impairment, little bit of confusion, sleeping issues. Those things can also impair functionality of the patient also. So there are things around so-called cure with medications, treatment with medication, but it's very, very important to keep a follow-up with the neurologist or a neurosurgeon and with the medications. Now there are these apps also available where one can put the data of the medicine, and the app will tell you, oh, you have forgotten to take this dose, you need to take it or not. It's a reminder app kind of a thing, which is again will be proven to be useful in management of epilepsy and prevent seizures.
Thank you, doctor. That was really interesting, sir, madam and sir. A lot of learning I'm having today, because I was just going to ask what happens if somebody has a trauma, somebody has had a fall, and then they start having epileptic seizures. So there has been such a case that I know of. So I thought I was going to ask that, but Dr. Bindu, and you have already answered this question. So then there is this question. There was one person who had actually said she had seizures 2 years or 3 years ago, but after that she had been on medication, but then nothing happened. And I think now she says she's in the morning, she's taking some medicines, and then she's Levipil, 500 mg, and then 1000 mg of Levipil, and well, I think she is also taking something for night for deficiency of calcium. So she had seizures in 2018, but then I think after that she's not had. So she wants to know what could be the issue, whether she would have it again. These are very sketchy details that she's given.
Yes, but then with the limited data, again the same dictum that if her EEG is normal, the MRI, the 3 test MRI with the epilepsy protocol normal, all the blood investigation normal, there is no, there is something like neurocutaneous syndromes, like it can occur at any point of your life, need not have to have occur in the childhood. Sometimes you might have some, brown kind of pigments around the body, and it may not throw a seizures. Some point of a time it will have to throw. So if you're having that kind of things that actually need a examination by the neurologist to, even if that's a single episode of seizures, we have to look. But I think if the MRI and the EEG, everything is normal, and if she does not have any further seizures, of course, 2018 first episode, and while on medications she had never, so she has to but consult a neurologist and has to, yeah, the neurologist has to review the first data, the first seizures and the imaging and the EEG, then can come to a conclusion whether she can stop it or not.
So here is another question. I think Dr. Rishikesh, this could be for you. My son is 16 years old and he has, oh, where did it disappear? Okay, I think that's gone. So anyway.
I think, yeah, I think I'm trying to answer. I saw that question. It's in the answered thing. My son is 16 years and he has had first seizures at age of 10. If we started his medication at the age of 13, and he gets a seizure in a span of, I think, every 3 months, followed by vomiting, headache, etc. But however, they see that the intensity is mild nowadays. How can we get it cured? He's on a single medicine. I think that Dr. Bindu, I think you should be able to answer that first,
Yeah.
I guess, because he's right now only on single medicine. I'm not sure about the dosage pattern, whether the dose is correct or not. So you want to just focus on something on that?
Seizures at the age of 3 years, and it was once where he had severe fever. At that, now he is 11 years. So there is some entity called febrile seizures.
No.
So that is from 6 months to 6 years.
No, Dr. Bindu, this is about different case. This is now the patient is 16 years, had a first seizure at 10 years of age, and started medication at the age of 13. He gets a seizure in span of every 3 to 4 months. He's having seizures. However, the intensity has become mild, but still he's getting seizures every 3 to 4 months. How can it get cured? He is in a single medicine.
Single medicine, but how much? I'm not able to see the question in my Q&A.
It's there in the
answered. If you open the question and answer segment, there is something called answered, where there are two answered questions. So this is the second question that's been answered.
Okay. What was the dose written on the first single tablet?
Right. So
given any dosage.
Right. So if I'll answer this actually. So I think what we need to do is we have to understand what kind of medicine he's getting, what is the dosage he's on, what is the body weight of this particular person, and what kind of educational and developmental activities he has had all this while, whether the medicine is causing problem or not. Essentially, he will require an evaluation by our team of epilepsy. And I think we would highly recommend, if he's in Chennai, to visit us. I think we're going to have a elaborative camp on this specific issue and address these things. It's very difficult to answer this directly in form of one single answer here. I have a feeling it might have to be do with the dosage of medication. As I said before also, most often these kind of a breakthrough seizures in a growing age is due to inappropriate dosage and dosage regimen actually.
Thank you, doctor. Here is one question to both of you. This is an anonymous attendee who says his son had a seizure when he was 3 years old, and it was just once because he had severe fever. And now he's 11 years old and there's been no recurrence, but then he's saying, should I be worried? Should I be concerned that it could relapse or it could come back at some other point in time?
Yes, if the baby is absolutely normal development with a normal EEG.
11 years old, so the child is not.
When the baby's first seizures had occurred at the age of 3 years, if the EEG was normal and the MRI was normal, I don't think there is a need to worry. Usually, there is an entity called a febrile seizures occurring in a totally normal children, absolutely normal development. from 6 months to 6 years. So that is because of the immature brain getting susceptible to the increase of the body temperature. So as the brain gets mature, so that goes off. So it's an age associated, now you can say a normal variation, but it will not have lifelong or long-lasting consequences. There is a rare group of individual in which these babies would also have some genetic epileptic vulnerability. So those kind of individuals also gets precipitated by fever, but they will continue to have seizures again. So in a typical febrile seizures, that will not occur after 6 years. Mind you, this we will at the first episode of the seizure itself, when the baby had a fever, if the baby was seen by a pediatrician or a neurologist, they might have evaluated and said that the EG was normal and MRI was normal, everything was normal. So there is no need for him to worry.
Sakar, do you want to add to it?
No, I think my expertise is not that much compared to Dr. Bindu in terms of febrile seizures, so I don't have anything to add on to that.
Thank you, sir. Thank you so much. So there is somebody here who's asking, is rehabilitation therapeutic? He says therapeutic exercise, is it helpful? Yes.
There is nothing like a therapeutic exercise,
Right.
but then by rehabilitation, what we would like to say or project is that simultaneously the patients might be having, in the case of children, the seizures might be having consistent developmental delay. Sometimes, if there is a decreased blood circulation to the brain at the time of birth, there will be spasticity of we call it cerebral palsy. So in these kind of individuals, we really need the overall treatment. It is not that the decrease in the seizure recurrence alone. We want to improve the quality of life of that child. In that situations, you obviously need to increase the locomotion ability. Plus, you need to make the child as a normal child. So whatever physical disabilities you have to realize about that, and you have to give appropriate treatment. There comes a rule of neurorehabilitation. And suppose a child had, have congenital malformations of the brain, which cannot be rectified otherwise. So they cannot be left alone. Just by giving medications for seizures, they cannot be left alone. So they also have to be brought back to the mainstream of, they should also they have a right to have a good quality life. In these situations, the neurorehabilitation has got an immense, especially the speech development can be done. We can give cognitive retraining. We can decrease the spasticity of the muscles and make them do whatever they can with the limited disabilities. So before that, we will assess how far the baby is disabled, and we can give appropriate physiotherapy. Means that will be awesome, because in the child, it's like, a clay, we can mold accordingly. As you become old, it's, when the joint becomes stiff, and it will be difficult. But in the early childhood days, if we have a disability, it's very, very, it's very actually moldable stage. So we can do a lot with the neurorehabilitation in a child with epilepsy. So that is the rule. And in adult also, we have, met with so many traumatic brain injury patients. Young boys, like, has a rash raised and met with an accident, and after the blue, they come with they were absolutely normal till then. So after that, they have a downhill horse because of the brain insult, so much of injury to the brain. And they also will be they might be in intensive care with a ventilator, with a tracheostomy, all those tubes instilled in the body. But then once they come out, and it is our responsibility to bring them back to life by giving that, locomotive ability, cognitive retraining, find out what all languages he knew, how to make him, communicate, whether his ability to comprehend is there. So all this, a patient alive means he should be able to, do the at least day-to-day activities to this minimum extent. So to make him that, we need to really go through in a rehabilitative point of view also. Just giving medications to decrease the seizures is not enough. That is only, I think, one part of it. That is the role comes for the teamwork. And I think, Dr. Rishikesh, do you want to add anything regarding this rehabilitation?
Rehabilitation essentially is focused on psychological and cognitive aspects and getting them enhanced where there is a background deficiency in those parameters, and somehow bring the child or young adults to a level where they can function independently. So the rehabilitation, the meaning itself is to rehabilitate them as far as psychological, cognitive, and social issues are concerned. And fortunately, at MIOT, we have an excellent rehabilitation center dedicated to neurological work, and also epilepsy forms an integral aspect of it. So it is a vital element in the treatment of an epilepsy, which is just not only control of seizures or control of any physical phenomena. And as Dr. Bindu pointed out in her presentation, it involves social, economical, and overall cognitive rehabilitation. Henceforth, neuro rehab plays a very, very vital role. As far as any single exercise is concerned to do with epilepsy, I'm not aware of, but pranayama therapy is supposed to soothe the nerves, and it's also supposed to control and regulate brain activity. So this is something which I can add on from my side. But however, I'm not again aware of any specific exercise pattern or so.
Thank you, doctor. And I think that is something that you have also spoken about. How many I think you have asked, how many of you think epilepsy surgery requires opening the head?
So I'm not getting any response in the Q&A because suddenly it's popping up. A lot of Q&As are popping up over here. So I'm distracted right now.
Okay.
So let the responses come that way. But we will take up some questions which I have answered over here, I guess.
I think there is another question. Like, my son is 2 years old.
Yeah.
He was born with HIE, and MRI shows multiple cystic lesions in the brain. He's already on 5 anti-epileptic medicines, and still the seizures are severe.
Yeah.
Multiple lesions. I think this goes to Dr. Rishikesh Sarkar. Multiple lesions in the brain. Can surgery be done?
Again, a very interesting clinical phenomena. We need to ascertain what the brain lesions are, whether they're infection or whether they need to be treated. This again requires an evaluation, cannot be answered directly over here, but I can say there's a potential. I can see a potential of an effective treatment and maybe cure. So they must get in touch with us and our team for better treatment and management.
Thank you, sir. So here's another something here.
Even if surgeries cannot be done, there is a role of neuromodulation. That means the role of putting battery, like the sir has already mentioned in his talk, vagal nerve stimulator. That is, you put a battery in the subcutaneously just below the collarbone, and trying to decrease the number of episodes of seizures by stimulating the vagal nerve. So that is called vagal nerve stimulation. So even if your child cannot undergo seizures, don't get upset. There are other modalities of treatment, especially in a case with, the poor mom. She might be very worried because of 5 anti-epileptic medications and still the seizures are so this still role, even if surgery cannot be possible also, these we need to really see the child, but the role of neuromodulation comes into the picture.
Thank you, ma'am. So here is somebody, another anonymous attendee, so is speaking about a cousin in Trichy. Her child, she has repeated seizures since the age of 4 years. Currently, the child is 7 years old. what's special about the social? I think this person wants to know what is special about the clinic. They say you can cure epilepsy. Would you please explain? Can you guide the cousin? The attendee is asking. So yeah, there is not much details about what actually the child is going through, but since the age of 4 years, I guess you should ask them to visit your clinic so that you can evaluate the child and guessing that's what you can do.
Yes. True. I mean, offhand we may not be able to tell you that that child can be curable or things like that, but we need to really see that baby who had seizures at the age of 4 years. So was there any cause in the brain or genetically? So we need to really know about that, whether EEG was normal or abnormal, and at what kind of epilepsy the baby was having. It all depends upon all these factors to finally come to a conclusion that it can be cured or not. So there are so many factors down the lane. I think it is advisable that if we could possibly bring that child, we can give more service to you and explain to you that what all can be done. Even if the baby is in Trichy, I think that's not a point. Like they can come and they can get an appointment and they can come. We'll give you our expert advice after discussion with all the teams.
So here is somebody called Karthik Chandran. So he says he's heard that children born with epilepsy do not achieve developmental milestones on time. So once seizures are stopped by treatment, do you think the children will lead a normal life? Will they lead developmental lives? What do you call milestones? Would they achieve them like normal children? I think that's what he wants to know.
Yeah, again, this depends upon the type of epilepsy, the cause of the epilepsy. There is something like genetic epilepsies, and there's something like an epilepsy syndromes. In that case, of course, it is a syndrome, means it's an epileptic. Along with the epilepsy, there will be that what that cause epilepsy is the one which causes developmental delay. So we may not be able to rectify it, but without knowing that, we cannot categorically tell that all the kids that is born with epilepsy will not achieve the developmental milestone. For example, like there is small babies in the newborn nursery, we often used to get calls like it's called benign myoclonic epilepsy. It's a benign myoclonus. So in the sleep, they will have jerks. The mother will, giving milk to the baby, will be seeing the jerks and it gets panicky. Bring to us. The EEG will be normal, and on follow-up, the development will be normal. So those kind of babies, even if the seizures is there and could stop, the development is not going to get arrested. That will continue to. So we need to see that baby with that epilepsy at that point of time, though it was a recurrent seizures, it did not interfere with the development. So like that, there are certain age-related epilepsy. We call age-related epilepsy means another example is called benign nocturnal epilepsy. It's called Brolandic epilepsy. So those babies will surpass that. Once they surpass the age, the epilepsy won't occur. They'll have a normal development. So the categorization of epilepsy, actually in the diagnosis itself, we have to find out what type of epilepsy the baby is having and whether it is fitting into a genetic syndromes. So all these factors, are to be considered before saying that the child will be normal. So if there's, I told you, in genetic epilepsies around the epileptic encephalopathies, it's called epilepsy syndromes. Best syndrome, Lennox-Gastaut, so many syndromes are there. So those babies, of course, the development will be affected. But the other category, where there is an age-associated epilepsy, they will not have any developmental delay, or there'll be mild delay, but then once the seizures are controlled, they will not having a recurrence. It's with age that will get, and with proper treatment. We need to really treat also, but it's for that short period of time. They can be normal later on.
Thank you, ma'am. Thank you very much. And
Thank you.
here is another question. I will just skip one question. I'll come back to that later. So, dear doctors, my daughter is 6 years old. She has bilateral occipital epilepsy. First episode on 17th February, second episode on 15th April. We have started medication, Levy pill. Are there any side effects of Levy pill? Then I think they've given even the dosage.
Yeah.
Maybe, sorry, I'm not good at this, but anyway, 100
Yeah.
syrup. So the child is on syrup. And can you please explain about ketonic diet?
Yeah.
She means ketogenic, isn't it?
Ketogenic diet. Yeah. It's a auto thing. So levetiracetam, I think 100 milligrams syrup means, I don't know what's the weight and how much the baby is getting. I think with the normal weight and the normal.
6-year-old, the girl is 6-year-old, and she has
6-year-old.
bilateral occipital epilepsy.
Yes.
The first episode was on 17th February, and the second episode was on 15th April, and they put her on this levetiracetam IP 100 mg syrup.
Yeah. So in a normal therapeutic dose, levetiracetam is not going to have much of a side effect. When it becomes a toxic dose, that is in children is around 40 to 60 milligram per kilogram. So we don't know the weight of the baby. If it surpasses that, senses, instead of drowsiness, they become hyperactive. Behavioral, in the forms of increased anger and all occurs, especially it's the toxic dose. But if the baby is within this, suppose if it is 20 milligram per kilogram, it is not going to have any much of a side effect. As per the side effect profile is concerned, levetiracetam is a good anti-seizure medication compared to the earlier medications like phenobarbital, phenytoin, which gives increased drowsiness. Phenobarbital and all, it's age-old thing. So the levetiracetam is a respectively safe medication.
Right.
Ketogenic diet is one diet in which you have to replace the carbohydrates. That means rice, wheat, bread, all those sugary items, and replace. So that means we are not going to touch any of those substance containing foods. Instead, we are using only fat and proteins. So every 3 to 4 gram of proteins for a gram of fat to 1 gram of carbohydrate. So the fuel is from the fat. That means you need to include cheese, you need to include butter, dairy products. Then you have meat, eggs. So all those fat containing fried foods, all those fat containing diet we can include more. But these are off label. If the baby is just having a bilateral occipital epilepsy, we need not have to really subject the baby to a ketonic diet, because these sort of particular diet are meant for medically refractory epilepsy, where you don't, the seizures are not controlled with the multiple medications. Because here, when we give, this is a normal child, and if we replace a carbohydrate, everything with this ketogenic diet alone, we have to give a lot of supplements, because this fat will not contain vitamins, fat will not contain minerals. So we have to give proteins. So at this point of time, our main agenda is to control seizures, plus the growth of the child also, because that is normal child, except for that bilateral occipital epilepsy, everything is normal for that baby. So we need an overall growth for the baby. So we need, it's enough that the baby takes the adequate balanced diet as any other individual. The aim of giving a ketogenic diet is for individual who is not responding to seizures, mind you. So that is, we are being done with supplementation of vitamins and minerals, because the ketogenic diet will not contain all these.
Okay.
So for him, for his daughter, I think that is not needed.
Okay. Thank you so much, ma'am.
Dr. Bindu, we have many questions over here. I think we'll just go quickly. There are many interesting questions.
Yeah. So there is this 22-year-old man who is suffering from grand mal seizures for the past 6 years. This year the condition has got worsened. So whenever I have sleep deprivation, probably of the probability of me getting seizures is high. So my question is, could you suggest if carbohydrates should be included in my diet? So he's saying sleep deprivation is causing his seizures. There's also somebody else who's also brought up the same issue. And
yeah, I think again it's related to the ketogenic diet and other things, I guess.
Yes.
Yeah.
Yes. So for sleep deprivation, I think we need to address the sleep issues. We need to have a sleep hygiene, a good sleep hygiene to control his seizures, rather than switching on his diet. So whatever diet that he is taking, he can, but we need to know what kind of diet he is taking, obviously. But I think that he himself knows that it is a sleep deprivation which is precipitating his seizures. So I think we need to address that issue.
Thank you, ma'am. So here is one person. My wife is 46 years old. First episode began at the age of 30, and her EEG and MRI were normal. But then she had to, I think they put her on some tablet, Torileva, SR 750. And now the episode occurs after 3 months, whenever she's stressed out. And so they want to know, should they continue the medicine for lifelong or can they stop? How does this work? I mean, like, should she take the medicine only when there is seizure, or should she continue?
The details are very, very sketchy to answer that question. It's very difficult to answer that medicine can be stopped or not on this platform. I suggest that let them take an appointment and seek a consultation for this, because this is a very important and pertinent issue. I don't think this can be answered on this platform. It requires a detailed EEG, a detailed analysis of her drug history and everything.
Thank you. So here is somebody who's it's an anonymous attendee. They want to know, she has been, I know whether it's a woman or a man, this person has been having seizures from birth, but it is not genetic because the parents didn't have it. Wants to know if her offsprings will have it.
That's again a very interesting question. Dr. Bindu, you want to answer the genetic epilepsies?
Which question is it?
There's an anonymous attendee and she says, I know it's a man or woman. They want to know, I am having epilepsy from birth. My parents don't have. This is, will my offspring get epilepsy? Please answer.
No, the epilepsy is a very, the genetic thing is a complex thing. There is no monogenic inheritance for a genetic. So that comes to the question that if the father is affected, there is no the situation that the child should 100% get affected or 50% get affected. So it's the monogenic means, autosomal dominant, autosomal recessive kind of inheritance. So that kind of inheritance is not there. Actually, it's a polygenic inheritance. So the baby or the person's child getting affected by this epilepsy, we may not be able to tell. But suppose if we find out the genetic, we call genetic testing. So if there is a genetic mutation of certain particular genes which is guiding the channels, we call it sodium channel, potassium channels, of which the abnormalities occurs and result in seizures. So if there is something like that, obviously, then we will be able to know that the child can get affected. Otherwise, speaking no, we cannot categorically say that the child can get affected because it's very complex and it's a polygenic inheritance.
Thank you, ma'am. So I actually want to know, Dr. Rishikesh has asked a question to all. He wants to know, what would you do if a person is having fits and is unconscious? I really want you to answer this question, both of you, because yes, we do see people having seizures, and honestly, we don't know what to do. I only know they ask you to put something in the mouth so that the person doesn't bite his tongue. But beyond that, I wouldn't know how is it easy, is it difficult to do something to a person when he's having a seizure on the road?
Right. Yeah, I think one has to remember in a situation like anyone faces a patient having seizure, 3 C's to remember. It's very simple. 3 C's. First is stay calm. In most of the situation, the seizures will subside spontaneously. One does not need to be very aggressive or does not need to be panicky about the situation and do things like putting water in the mouth or putting sandals or there are many weird things people do it. But staying calm is the first thing, the first C. Second would be cushion the head, or basically what it means is make sure that the patient is not somewhere in the vicinity of any hazardous substance. Anything at elevation, anything close to fire, anything in an adventurous kind of a situation. So coming injury. And third, call for the help and make sure that the patient gets a medical help as soon as possible. These are the basic C's which anyone can do, irrespective of the education, irrespective of the background of any medical knowledge or so. Stay calm, cushion or protect the head, and call for help as soon as possible. Do not do anything which can further jeopardize the situation.
Thank you. I think we should close the event here now because it has been very interesting. And in case we get questions, if there are more questions that are coming our way, we will just mail it to you both so that you can answer them. But I think mostly people who have asked questions need to come and visit you because their conditions may not be serious, but they are recurrent and they need medical help.
Another important thing I just want to highlight here is every patient with an epilepsy has a risk of something called as SUDEP or sudden death. This is something which is very, very important to understand. And the risk of SUDEP is particularly high in children. And if there are parents who would wait and okay, there's a one seizure and once in 6 months, once in 4 months, what difference does it make? But the data overall the world, it shows that in particularly in children, there is a 0.8 to 1.8% chance of a cumulative risk of sudden death due to an epilepsy or due to epileptic attack or so. And that's a cumulative. That means as the age advances, this number is going to increase by about 2% every year. So patient is having a fit, or baby is having fits at the 2 years of age, and this risk would probably, the risk of having a sudden death would increase to 10% at the end of 10 years or so. Therefore, it is very, very important and pertinent to manage seizures with medications, with proper consultation with doctor, and being compliant with medications. And yes, in case the medications do not work and seizures still continue, we definitely can offer as a surgery for control and even in some cases cure.
Thank you very much, Dr. Sarkar. Thank you very much, Dr. Bindu. It has been a very enlightening session. Session where I learned a lot. Thank you.
Thank you, madam, for elaborating.
Thank you very much. Thank you very much, Hindu, for giving us an opportunity. And also I thank our MD Miyot Hospital for giving us an opportunity to throw some light, at least, on some aspects of epilepsy care. Thank you, madam. It has been a fantastic experience talking to you and with the public.
Thank you.